Okay, so I am giving this presentation tonight. I planned on giving it live tomorrow, but with a few issues going on with family, my mother, who's my normal babysitter, couldn't be here for the hour that I needed to give it tomorrow, so I'm going to go ahead and record tonight. So my presentation is going to be on infertility. It's something that my husband and I struggled with. It's something that I know a lot of people struggle with, and something I'm pretty passionate about. So I hope I can be of help to you if you ever see anybody who struggles with infertility. So we'll start with the Self of the Therapist. I linked a really good resource here on family history. You can use this for your own family health history, or you can use it with clients to give it to them to create their own family medical health history, or you can just use it with them. It's really simple and easy to use, and it really helps me get an idea of all the different health problems in my family. So it's just a great tool. So the website actually created this that you're seeing on the screen now, this family tree diagram. So I included myself, my daughter, my sister, my parents, and both grandparents. So as you can see, I have one of my grandfathers passed away. Other than that, we have the key there. So it really gives you everything, which is why I thought it was such a great tool to use, and why I wanted to include that and actually use this in the presentation instead of creating my own. So along with the diagram you just saw, the family tree, you get this chart that you can use, and it's got everybody that you discussed. I cut off my daughter in this one because she doesn't have any issues. She was preemie, but no health issues relating to that. So you start with self, and the two issues that I've had in my lifetime, polycystic ovarian syndrome, PCOS, and unexplained infertility. So those are kind of the two that I'm going to focus on today, but I'll go ahead and run through the rest of our family as well. My dad has had some major back problems with 2 surgeries. My mom has high cholesterol and high blood pressure. Thankfully, I've not inherited that thus far. My dad does not have either of those, so I'm hoping to inherit his cholesterol and blood pressure rather than my mom's. My grandmother, my mom's mother, actually has high blood pressure. She has, and she has high cholesterol. So you kind of already see a relation, like some of the things that my mom has from some of the things that her mom has. And then my grandmother also had breast cancer. She got it when she was pretty young, right around 50. She was able to treat it with radiation only, but my mom and my sister and I have been closely monitored since due to her breast cancer. My grandfather, my mom's dad, he has diabetes, recently diagnosed. He also has high blood pressure and an irregular heartbeat. He has a pacemaker in. But really, you can really look, my grandmother and my grandfather have high blood pressure, and so does my mom. So you can really see that that may have been something inherited for her. As for my dad's family, again, my dad is very healthy. My dad's dad died at age 60 from hepatitis. I believe it was hepatitis B. He had kidney stones all throughout his life. He also had a stomach aneurysm when he was 30, and that's actually how he passed away. Later, they were able to save him from the stomach aneurysm. They said then that only about 2 to 3% of people lived through what he did, but he had to receive a lot of blood. And that was really before they did a lot of testing to blood. And so he got sick when he was about 58 or 59, and they realized that he had hepatitis B, and it was from the blood that he had received when he had the stomach aneurysm. So, no hard feelings there. I remember before he passed away, him saying he was glad he took the blood because it kept him alive for as long as it did. But, we did have the hepatitis, which led to liver failure and eventually killed him pretty quickly. And then my grandmother, my dad's mom, she has Meniere's disease, so really bad inner ear and hearing loss. So those are the two things that she struggles with. And so you can kind of see as a family, we're really all over the board, minus my mom and both her parents having high blood pressure. So it's pretty interesting to see what you might have inherited, what you might not have inherited. And as this goes, you can go in and add things to this. You can save it. I actually have it saved on this website. So as somebody in your family gets some illness or as something goes on, you can go in and update this and it keeps it in this chart for you. So as a patient, I told you I was going to talk about infertility. I had ovulation problems. I started with an OB who tried ovulation medication for 3 months. I tried a medication called Clomid with absolutely no success. Typically, before you're referred to a fertility specialist, you have to wait 1 year of unsuccessful conception attempts. But in our case, we knew we were having some problems, and which is why we went to the OB when we did, after we'd only been trying for about 3 months before we saw our OB. And then I knew that something was a little off, so we went to our OB, we tried that, and she went on ahead and referred us to a fertility specialist, because if you are diagnosed with something before the year is up, you can go ahead and see a fertility specialist. So with a fertility specialist, after multiple tests, I was diagnosed with polycystic ovarian syndrome. It doesn't present itself like many typical women who have polycystic ovarian syndrome, but I do have some of the classic symptoms. I tried ovulation medication from Mara for 4 months. I also took a trigger shot with that to help me ovulate. We were successful with ovulating 3 of those 4 months, but we were unsuccessful at getting pregnant. So they did more testing after those 4 months because the fertility specialist was pretty convinced that that should work within 3 months. And then they also diagnosed me with unexplained infertility. So they did ovulation medication with a trigger shot, and then they did the intrauterine insemination, which was successful in the first try. And so that was interesting because when we saw a fertility specialist after we had failed the 4 months, when we did the more extensive testing, he was fairly convinced that the IUI would not be successful. For what I was diagnosed with, even with the unexplained infertility, they gave me a 1% chance increase of getting pregnant. So we were up to about an 8 to 10% chance that we would get pregnant. And he told us, we'll try this IUI for 3 months. That's kind of just the succession, even though he didn't think it was going to work. And he had really prepared us to go on to in vitro IVF. And we were very thankful that that did work on the first try. It's still unexplained as to why it's worked. But I guess that's why I have unexplained infertility, so we're thankful. Throughout pregnancy, we had a little bit of problems. The fertility doctor monitored and managed our pregnancy for 12 weeks. At 5 weeks, we were told to be prepared to lose our baby. The hormone levels in me were not increasing as they should. I also had the placenta had not completely attached correctly, so there was a pretty big blood spot in my stomach. So, that was a pretty heartbreaking time, but when they went on ahead and set up an appointment for 7 weeks, and they said we would probably know more then whether we lost the baby or not. At 7 weeks, we heard the heartbeat. The doctor was cautiously optimistic, even though we had heard the heartbeat. He said that, we still needed to do a lot of checking. At 8 weeks, the baby measured a week small. but she was growing. And so, again, it was good news, but still very cautious. He did let us go 4 weeks without an ultrasound. So at 12 weeks, we went back. The baby measured 10 days small, but she had everything that a 12-week-old should. She was just small. So all seemed to be developing well, and I was released to my regular OB. At that point, the baby measured small the entire pregnancy. It was nothing new to us. Every ultrasound, we had lots and lots. She was small. I measured small starting at 30 weeks. At 32 weeks, I was my biggest in pregnancy. I gained about 13 pounds. By 34 weeks, when I went back, they gave me steroid shots to help the baby's lungs grow because I had lost a couple of pounds. At 36 weeks, when we went back, we learned that it was a Friday, we learned that we would have an emergency C-section on Monday morning because the baby was small. There was very little fluid left in my body. There was very little fluid left in the baby, but she was doing really well. She was still small, but she had measured small, so we weren't really concerned there. So that's just kind of how that progression went. She had more shots to help grow her lungs again at 36 weeks. By the day I delivered, I'd only gained 9 pounds, so I lost a pound a week starting at 32 weeks. So when she was delivered, the OB had told us later that day that it was a good thing she delivered because it would have been extreme emergency by that afternoon. I had no fluid left in my body, and she had very, very little. So my body from 5 weeks on almost didn't want to carry the baby. You know, my body didn't want to carry her at first, and we overcome that. And then towards the end, it was ready for her to get out. It wasn't anything with the baby. She was healthy and fine. It was my body. So that was interesting. And this is part of the reason why I'm so interested in fertility. After you go through something like this, even though we didn't have the year of failed conception. We did only have 3 months, and then 3 months with our OB, and then 5 months with the fertility. So we were just at a year. We actually started trying in November of the year before, and we got pregnant in November of 2016. So we were 1 year exactly to when we found out we were pregnant. So I was fortunate with that, but every month was difficult. Those first 3 months weren't awful, but starting when we went to the OB and we're on the medication, it was tough. Not only were you going through a lot personally, it was very upsetting to see a negative pregnancy test month after month, but then you're also on a lot of hormones. I was on many things besides just the ovulation medicine to help with hormones, and so sometimes I felt like a crazy person, but it was worth it. So patients have a relationship with their healthcare providers. With our fertility specialist, he checked our insurance coverage for behavioral health services in case they were needed as we went through the process, but he did not recommend one certain provider. So I thought this was really interesting and really applied to us in this class because my fertility specialist did mention behavioral health every single time we were there. From appointment 1, they checked our insurance coverage for what behavioral health coverage we had in case I needed it or my husband needed it or that we both needed it before the process was over. They gave us a flyer about support group meetings once per month at the fertility clinic. The doctor discussed the importance of good self-care in order to get pregnant, and that included mental health care because you are going through the stress of trying to get pregnant, and so maybe that's not great for getting pregnant. And then the doctor also asked about my emotions and feelings, depression, anxiety, and etc. at each visit. He was very concerned with emotional well-being and encouraged seeking mental health care if necessary. So that was really interesting to me, and I didn't notice it as much as at the time until I had this class of how important it was for him to be connected to the mental health side of things, and recommending mental health care if we needed it, and just checking on it every time so that he knew how things were going. So as a therapist myself, we discussed the levels of systemic collaboration between therapists and other health professionals. My fertility doctor was a basic collaboration off-site. He did have some people he recommended. We never asked for them, but there was nobody on site at Nashville Fertility. There was a support group, but it was from a counselor who came in once a month. As far as personally, my current level in my position as a school counselor is between minimal collaboration and basic collaboration off-site. I do not work at a medical facility or somewhere with medical professional on staff. We have a school nurse, but there's not a lot of collaboration there. I do offer referrals to doctors, but do not receive referrals or communication. I attend collaborative meetings and trainings with community, medical, and mental professionals, and I do feel that I can handle basic biopsychosocial issues. But again, I'm somewhere in between stage 1 and 2, level 1 and 2. So to go on to the infertility, after I've given you a little background of ourselves and why I chose infertility, which is more than I've told a lot of people, infertility is something that we kept pretty private, my husband and I. So this was a good project for me. It was something that kind of helped me personally to talk about it a little more. So female infertility affects about 10% of the population. Infertility does in general, not just female. The diagnosis is typically given after unsuccessfully trying to conceive, including miscarriages for 1 year. Again, we did not have 1 full year of trying, but they were able to diagnose early, which is why we had that diagnosis before a year. Female infertility is responsible for 50% of all infertility cases and 1/3 of infertility cases alone. So basically they say that female infertility is 50%, male infertility is 50%, and then total female is 1/3, male only is 1/3, and male and female together is 1/3. And obviously if both male and female have fertility issues, those are the hardest to get pregnant. Thankfully, I was the only one in our relationship that had the fertility problems. Everything tested great with my husband, so it was just me. So our odds were a little better than if it had been both of us. The most common causes of female infertility: ovulation problems, damage to the fallopian tubes or the uterus, problems with your cervix, age. People who are over the age of 35, they recommend see your OB as soon as you get ready to start trying. And a lot of OBs will refer within the first 6 months of somebody over the age of 35 because it is more difficult to get pregnant. Abnormal cervical mucus is another common cause, as well as hormone problems. So ovulation problems, some of the causes to those are hormone imbalance, cysts, polycystic ovarian syndrome. So both of those, I have the hormone imbalance as well as the cysts. So my issues kind of started with the ovulation problems. Eating disorders can cause ovulation problems, alcohol or drug use, thyroid issues. I know personally one of the first things they tested for was thyroid issues within me. Thankfully, that was not the case. Excess weight, stress, intense exercise that caused a lot of weight loss, and irregular menstrual cycles. Those are causes of ovulation problems. Damage to the fallopian tubes or uterus, pelvic inflammatory disease, some type of infection, endometriosis, chronic medical illness, ectopic pregnancies, birth defects, scars, different things like that cause damage to the fallopian tubes or uterus. There's a test they can run, an HSG test where they clean out your tubes, and so that would help see if there was damage to the fallopian tubes or uterus. So those were the two big ones, which is why I discussed those, because those were the two that had a lot of subcategories within them. So how is infertility diagnosed? A physical exam including medical history, urine test, blood test, pelvic exam, ultrasound at various points during a woman's monthly cycle that can be done vaginally and or abdominally. A sample of cervical mucus, the HSG test that I discussed to test for fallopian tube blockage, hysteroscopy, I almost said hysterectomy, not the case, to look for uterine abnormalities, as well as a sonohystogram to look for uterine abnormalities. We never had the last two done. I didn't, but we had everything else. So I am familiar with the first many things on this list. Is infertility preventable? Because I know when we went through infertility, and we did tell a few people, there was always advice on how we could have prevented it, how we could still prevent it. Technically, female infertility is not preventable. There's nothing that I could have done differently to prevent having infertility or prevent being diagnosed as unexplained infertility. But there are some things that you can do to help. The first is to take steps to prevent sexually transmitted diseases, because those are linked to infertility. Avoid illicit drugs and excess alcohol. Good personal hygiene, and maintain your annual OB checkups. That last one is super important because they can catch things early. They can help you stay healthier. So while it's not preventable, there are some things that you can do to maybe help control it a little bit. As far as treatment, there are lots of different treatments depending on what you have. Some of the most common treatments for just across the board infertility: hormones, orally or injected; medication to stimulate ovulation, orally or injected; supplements to enhance fertility; antibiotics for infections; minor surgeries to remove blockages or scar tissues. You can have an IUI, which is intrauterine insemination; in vitro fertilization. Those are called active reproduction techniques, ART, A-R-T. And those two treatments actually account for less than 3% of fertility services. And so I didn't realize that until I did this presentation, that those two things are very uncommon. I thought that our fertility issues weren't too bad, so that an IUI was probably really common, but it really accounts for less than 3% of all fertility services. Most things can be treated with a minor surgery, hormones, something of that nature. So specifically within infertility, I'm going to discuss PCOS. It affects about 5 to 10% of women, and there's a very high infertility rate with PCOS. Common causes of anovulation, which is what leads to the diagnosis of PCOS, is that you have very regular ovulation and infertility. So ovarian follicles mature to a certain point and no further, which causes no eggs release. So that's what PCOS does, and that's why you can't get pregnant, because you have no egg release because you're not ovulating. The maturation of follicles may be stunted due to an increase in male hormone testosterone. That was one of the first things they checked when we were diagnosed with, when we went to the fertility clinic. They tested my testosterone level, which was not elevated as much as a lot of women with PCOS, but was elevated above an average range. So PCOS is actually thought to be insulin resistant, which is a cause of weight gain or lack of weight loss. Many women with PCOS are overweight. That was another thing that didn't present itself normally in my case, but not all women who have PCOS are overweight. Some are underweight, but weight gain or lack of weight loss is a very common symptom, one of the most common. Typically, PCOS causes irregular or no menstrual cycles, and polycystic ovaries are seen on ultrasounds. The ovaries contain small cystic structures, which is how they're able to see if you have PCOS or not. So as far as treatment, your chances of getting pregnant using fertility treatment is very good. So although infertility rates are high, your chances of getting pregnant is still very high as well. So to treat PCOS, they induce ovulation. Clomid medication is oral. That's usually the first line of treatment. That's what we tried for 3 months first, unsuccessfully. We moved on to Femara, which is another oral medication. It was actually first used to treat breast cancer patients. This is a different dose, but it helps to make you ovulate. And it's the line of treatment after Clomid doesn't work. They do use Clomid first. Metformin, which is to treat insulin resistant, and that's usually in combination with the other treatments. You don't usually take metformin alone. You can, but it's usually with the Clomid or with the Femara, and that's to help your body produce what it needs to help you get pregnant. There's also daily shots. That's the next line of treatment after the Femara. They're expensive. Your risk of multiple births is very high. It's inconvenient to take shots daily, and you risk ovarian hyperstimulation. We did not try the daily shots. It just wasn't something that fit us well. It wasn't something, after the Clomid failed and after the Femara with the trigger shot alone failed, he did not feel confident that the daily shots would increase the risk of pregnancy at all. So there's also shots to induce ovulation, which is what we had. They're given with Clomid and Femara. They're called a trigger shot. You put those in, you take your Femara, you wait so many days, then you put the trigger shot right in your stomach after you have an ultrasound to see if you have any eggs that may possibly be able to release that month. Then you also can go to IUI, intrauterine insemination, and in vitro fertilization. Both of those success is higher for younger women, as is most all fertility treatment. There's also potential surgery, but it's not a typical treatment. I'm not going to go into detail on that because it's just something that is very, very uncommon. So your expected monthly success rate, after I talked about the different types of treatments, I just want you to be able to see the success rate. Metformin alone, 1 to 2%. Clomid, 15% if it causes ovulation. It did not cause ovulation, so obviously we had no % chance. Femara, if it causes ovulation, it did, along with that trigger shot. Daily shots, 20%, so you do have a little bit of a greater chance with the daily shots. And then in vitro fertilization, 60 to 75% in the first month for women under 40. I did not include the success rate of an IUI on here because typically IUIs do not work with people for PCOS. It's not a line of treatment that most fertility doctors try. But again, my PCOS was then turned into also a diagnosis of unexplained infertility, which is why we did try the IUI. So infertility, this is it's a quote I found, and it's something that we didn't experience a lot of, but I can relate. So infertility challenges everything. Your beliefs about yourself, about what's most important, about marriage, about what's fair and just, about God. Being infertile makes you question the purpose of marriage and of life. Nothing is left unaffected by this experience. It changes you subtly but profoundly. Being infertile changes everything. And so again, while we didn't experience the struggle that a lot of couples experience, we did experience a struggle, and I can relate to a lot of this on many levels. So the relation to mental health, we've talked a lot about the physical side of infertility. I've given kind of a brief overview of infertility as well as a little bit more of an overview into PCOS. Early research thought that about 50% of infertility cases were psychological, and the other 50% were physiological in the female. New research informs that the vast majority of infertility cases are physiological. They are not psychological. But years ago, they thought that 50% of cases were psychological. So infertility and mental health have always had a very close relationship. Although the cause of infertility is overwhelmingly physiological, the heartache, the stress, the emotions can take a great psychological toll on women. And so we're going to focus on women through the rest of this presentation with mental health. As far as psychologically, half of women polled in one study were seen consecutively at a fertility clinic. They reported infertility as the most upsetting experience of their lives. There was also another study of women with infertility, and it concluded that the women felt as anxious and depressed as those with cancer or those recovering from a heart attack. And so the study went on to say that procreation is the strongest instinct in the animal kingdom, which is why they felt that the women felt as anxious and depressed as those with cancer or those recovering from a heart attack, and why women rated that as the most upsetting experience of their lives. So factors influencing the psychological stress, this was in order of importance for women, and this was in another study. Having children is a major life focus, so that's number one. Number two is the female role and social pressure. And number three is the effect on your sexual life, so with your partner. And I think those really are great for mental health practitioners to know, because having children is a life focus for women. There is a lot of societal pressure to have children. As soon as you get married, people ask, when are you going to start a family? Well, I just did. I got married. We started a family, the two of us. But that's not good enough. They are waiting on you to start a family that includes children, and fulfill your role as a female, as a wife. And so that's a lot of pressure on a woman, especially one dealing with infertility. And then the effect on your sexual life, and we're going to talk more about that in a bit. Some of the most common things that I heard, some things that I got out of some of the studies: don't worry, it will happen. Try not to stress. You need to control your emotions so they don't harm your chance to get pregnant. If you stop worrying about it, it will happen. So those are frustrating to women who are trying to get pregnant. But again, they're said, and so I just wanted to include a few of those, just so as mental health counselors we know what's said, and we know how to better deal with these women, how to better help these women. Women, more so than men, experience emotional stress relating to infertility because they show a stronger desire to have children than men. It's that maternal instinct that we all hear about. That desire is typically stronger in women. That's not the case every time, but again, typically. Intensity of emotional distress often depends on early prognosis and length of treatment. So I felt like my emotional distress was not super intense. On a scale of 1 to 5, I'd probably put it at about a 5 while we struggled through that. But we had an early prognosis, and our treatment was within a year. So every month that went on, I felt like that increased a little bit. When we first found out that we may have trouble having children based on anovulation in me from our OB, I would rate, my mental health distress, emotional distress, as about a 2. I was worried about it. I was anxious, but the prognosis was good. So the longer the treatment went on, we probably got up to a 5 as far as emotional distress. Infertility patients often experience grief. Clinicians call it anticipatory grief. They're grieving something they really don't know that they're not going to have, but they don't have it at the time. And they're anticipating not having it because of the prognosis. Depression, anger, frustration, low self-esteem, lack of self-confidence, inadequacy, mood swings, a sense of urgency, guilt, self-blame, fear of limited control, fatigue, preoccupation with conception. Those may also be present, and I know I went through that list pretty quickly, but those are just some of the emotions that women may feel. Relationships, both marital and friendships, may suffer due to the emotions and isolation of infertility. Infertility can also exaggerate past and present mental health problems. So women who have already been diagnosed with a mental health problem are more likely to have mental health problems when they experience, or if they experience, infertility. Does stress cause infertility? So That's one of the things that I wondered as we went through infertility, because everybody told me, don't worry and it'll happen. Just stop worrying and it'll happen. You know, if you stress out, it's going to make things worse. So the answer to that question, which I thought was really neat and something I read, it said, rape victims are able to conceive. So that was their answer to the question, does stress cause infertility? That statement, rape victims are able to conceive, leads to the notion that some women are more reproductively sensitive to stress than others. So yes, stress could have an effect on infertility. But no, it does not cause infertility, because can you imagine the stress that a rape victim is under, yet some of them still conceive during that experience? It's highly unlikely that stress independently causes infertility. Women with a history of depression are twice as likely to experience infertility, so we do see a link there. But again, it's highly unlikely that alone stress causes infertility. Women experiencing infertility should practice relaxation techniques and experience mental health care, and that's just to help limit the stress during the fertility experience, so as to hopefully not be one of those women who can link stress to infertility. Mental health side effects. So infertility comes with a lot of medications, drugs, and added hormones. Some of the side effects, the Clomid, anxiety, sleep loss, mood swings, irritability. Other medications, depression, irritability, anxiety, weight gain, diminished sexual desire, menopausal symptoms, and more. It's difficult at times to determine what is caused by the medication and what is caused by the psychological impact of infertility treatments. So is the irritability caused by the psychological impact, or is it caused by the medication? A lot of times it's caused by the combination of both. Outcomes and choices. So when you're experiencing infertility, when conception is successful, you stress about successfully carrying the baby. I know that I did, especially after that 5-week checkup when they told us to be prepared to lose our baby. When conception has failed multiple times, there are decisions about continued treatments. How far do we go? How long do we continue this? There's also the possibility of multiple births. And so as you go through those treatments, some months your practitioner may say, I don't recommend you proceed with the treatment this month because you have too many eggs and you risk multiple births. As far as financially, there are only 15 states that mandate insurance coverage for infertility treatment. Tennessee is not one of those. I do know that from personal experience. I encourage you as a mental health practitioner to know whether your state mandates insurance coverage for infertility treatment or not. It's just good knowledge when you have patients. The average cost of in vitro fertilization is about $15,000. Other fertility cycles, depending on the treatments you need, range from anywhere from $100 to about $5,000, and that's per month. So there are financial hardships that can cause psychological stress. As far as religion, a lot of women experience spiritual crisis. God is not answering my prayers. Am I being punished for previous behaviors? Does God think I will be a bad parent? Those are just a few of the things that may go through a woman's head as she is experiencing infertility, especially if she's religious. Certain religions shun or even forbid fertility treatment, so that's good knowledge to have, because if you have a patient who comes in and their religion forbids fertility treatments, you're going to have to work with them around that and help them decide what to do there. As far as your job, there are numerous appointments that take much time away from your job. I missed a lot of work, about 2 days a month when we went through the fertility experience. And then we also missed some other time here and there. It is difficult to avoid coworkers' questions when a lot of work is missed. Actually, the one person who knew that what we were going through was my coworker, because he did notice that I was missing a lot of work. And then as far as other side effects, there is an inability to travel due to a sexual intercourse schedule, as well as a schedule of appointments. So that's something that you may experience, and a dramatically altered lifestyle. And again, that kind of goes with the inability to travel and the need to be around and available for appointments and scheduled intercourse. Infertility is one of the few diseases where the patient is often blamed for the illness. So when somebody has cancer, when somebody has some other type of illness, they're not blamed for what they've done. They're not blamed. We don't say that the cancer patient caused their cancer, but in infertility, a lot of times the patient is blamed for the illness. As far as marital relationships, they can suffer during times of infertility. This is one thing that I think a lot of people don't realize until you go through this. This is something that, as a counselor, I hope to be able to help people with as we go. Your relationships can suffer increased anxiety as you try to conceive, which can cause sexual issues and dysfunction, association of sex with failure, only interested in sex during times of ovulation, lower levels of satisfaction, and loss of confidence in your own body are just a few of the things that can cause sexual issues. The lack of communication of emotions. Partners respond to infertility in different ways and don't always communicate those very successfully. Timed and scheduled sex to fulfill medication protocols may cause relationship problems, as well as physical discomfort and hormonal changes in women. With counseling, the goal of counseling for infertility patients is to increase resiliency. Ideally, counseling would begin before infertility treatments start, just to provide a better mental health foundation, because better mental health may increase the chances of conception. Some studies say yes, some studies say no, but there is evidence that better mental health can increase the chance of getting pregnant. As far as areas of counseling, you can provide decision-making counseling, you can provide support counseling, so relaxation techniques, discussing medical treatment options. You can provide short-term crisis counseling to help increase coping skills. And then there's always the therapeutic counseling to help treat anxiety and depression, help with communication skills, help with relationships, and the marriage and sexual problems. Counselors should help couples identify and express their feelings regarding infertility, should help couples externalize the experience of infertility and related difficulties, should help couples develop strategies to help with the stressors and emotional pain related to infertility, and should help alter negative coping patterns and for marital adjustment. They should also acknowledge a couple's loss and help them process their grief, just as you would help somebody process any other grief, and provide the support and understanding that a couple may not receive from friends and family. Counselors should not fail to recognize the severity of the infertility experience, fail to fully validate the experience, or focus on individual or relational symptoms the clients experience, rather than acknowledging infertility as the stem of these issues. And they should use a biopsychosocial model, ideally. So as far as assessment, counselors should seek to understand individual symptoms, couple dynamics, social cultural backgrounds, and ways in which these interact with respect to the infertility experience. Look for presenting problems, depression, anxiety, common presenting problems, relational problems with their partner, religious or spiritual problems, identity problems, and any type of sexual disorders. A couple of screens that you can use. The Screen IVF, it was developed for medical professionals to assist in identifying patients needing a mental health referral. But you can also use that as a mental health professional to see what type of mental health care your patient may need. There's also the Fertility Quality of Life tool, which was developed to assess the impact of fertility issues and treatment on personal, social, and relational life. So if you have an interest in that, please look those up. They're very good tools. In counseling, the coping skills that probably are the most common Set realistic goals, develop an awareness of stress and stressors, realize it is okay to be emotional and respond to infertility in your own way. Talk to other people going through infertility, so support groups. Overcome isolation of family and friends. Counselors can definitely help couples develop a plan to communicate with family and friends. Give yourself permission to cry and be angry. Give your partner permission to cope differently than you. I think that's a very important one, especially to improve the relationship there. Improve your communication about infertility. Tell your partner how you want to be helped. So counselors can help with all of these things. They can also recommend keeping a journal, recommend that couples allow themselves time to grieve, help couples recognize old coping mechanisms and try to implement those currently, increase or develop spiritually, pay attention to those unnecessary shoulds. I should be pregnant by now. Just using the word should maybe should be discouraged. So a counselor helping couples pay attention to that would be very helpful. Take care of your health and learn techniques for coping with sexual stress to keep sex intimate. Avoidance coping strategies increase psychological distress, and individual coping strategies have an effect on one's partner. So those are just two things to make note of. And again, these coping skills are just suggestions for counselors to help couples cope as they go through this, not only self, but in the relationship. And so these are the references, these are the sources that I use. I hope that you guys enjoyed this. I hope that you can take something from this. As counselors, you may see somebody who's experiencing infertility. It may be somebody who doesn't present with that issue, but that may be the cause of their presenting issue. So just know these things, especially when you have couples. It may be something really good to bring up with a couple. Are you trying to get pregnant? How has that process been? Is there any infertility? Because it can have a great effect on that, just as I mentioned in the relationship portion of this presentation. So thank you for listening, and I hope this helps someone.